Okay, so let's start with our case presentation today. So if you are attending for the first time, this is an absolutely friendly discussion. So feel free to interrupt or to raise an opinion or a question. So you can simply unmute and speak to me, or there is also a chat box and a question and answer section. So feel free to share your ideas, and it's actually uh, essential part of the teaching is sharing thoughts here. So I'm going to start with the clinical data. I'm sorry. So here is our case today. So he is a 65 years old male, and he initially presented to the emergency department in the hospital where you work at. Uh, he um, uh, he lives alone, and you later on you have been asked for a neurology input following a delayed recovery. So let's start with our. So let me just I think the sort of voice. Okay, so so this gentleman lives in his own in his house, and was found unconscious at home by friends, and ambulance called and was found soaked in urine with no evidence of bruising or tongue biting. The medical history was significant in hypertension, type 2 diabetes. He's a smoker, and he had a history of ischemic heart disease. His family members report that apart from the already established histories, established conditions, he had few episodes of transient loss of consciousness over the last 4 months, and this was currently under investigation. Um, so this is his emergency initial assessment. He was found hypotensive. He was at a blood pressure of 80 over 35. Heart rate was okay, glucose okay, temperature was within normal as well. His initial bloods showed a blood count was normal, but impaired kidney function and a sort of metabolic acidosis, likely derived by the lactate. So, and he was initially assessed for his unconscious state, admitted immediately to the ITU, and later on there was no apparent cause revealed, and you were asked later on for an input. So on day 5, you found a no meningism, sluggish pupils bilaterally, but however reactive, oculocephalic reflexes preserved, and no response to pain, either to with eye movements or movement. This is, however, confounded by but might be confounded. There is no available information if he's under sedation or not. So you had 2 scans, and we are going to discuss them today. The initial CT head, and later, after 5 days of delayed recovery, an MRI was arranged. And I'm going to share them with you now. So that's the initial one on admission. Okay. So what are your thoughts on that, on this initial CT scan? Has any particular thing picked up your eyes? It's grossly normal, isn't it? So it's nothing particularly impressive. Actually, the initial CT is um, maybe can be one of the initial workup to reveal if this is particularly if the unconscious state is related to anything intracranially, for example, a subarachnoid hemorrhage, a hidden trauma or tumor, or a seizure provoking pathology. But apparently this was okay, and there's nothing particularly beyond that point. So the cortical ribbon is okay for his age. He has an excellent cerebral volume overall. Basic ganglia preserved with a gray-white differentiation initially. A brain stem is okay, and apparently there is no particularly focal neurology, to suggest maybe a brainstem stroke or similar. So day 5, he had his ITU support and intensive care support, but he did not recover. So we started to have a further evaluation with an MRI scan. And I'm going to share this with you now. So we'll start with our preferred sequence, the FLAIR. So that's a temporal lobes, upper brainstem, orbitofrontal, temporal lobes, occipital lobes. Then insular region, ventral basal ganglia, then a little bit higher. It's a frontotemporal occipital with basal ganglia and thalami. So that's a very well rehearsed level of the brain we all know about. Okay. Okay, so what's your thoughts? What are your thoughts? What picked up your eye? So Dr. Diana is mentioning hypoxic ischemic encephalopathy as HIE, which is absolutely making sense in this context. Yeah, but what I'm really asking about is what not particularly the diagnosis. What are the abnormalities? What are the description of what's going on? Any volunteers to maybe speak it out? Okay, so I'll briefly go to them, but let's go to the next sequence. What would you prefer to look after looking to this FLAIR? So which particular sequence would be helpful in your, sorry, let's get back to the screen. Okay, so which particular sequence would be helpful next to the FLAIR here? Yeah, Dr. Mariam is mentioning DWI, diffusion weighted. That's absolutely correct. Yeah, that's the second sequence we would like to look for. I'll briefly grab back the pre and post contrast of T1. Doesn't particularly reveal any suspicion, apart from it looks like this is an effacement rather than a leptomeningeal enhancement. This is just the congested blood vessels and an effaced parieto-occipital region, but not particularly an abnormal finding. And here is a FLAIR. Okay, so based on the clinical and the radiological data, what we would like to come before interpreting any imaging data, what I would like to reach maybe a short list of the differentials. What are the top 3 differential diagnoses here in this clinical context? The clinical context of an unconscious patient with delayed recovery in the ITU following supporting his low blood pressure and abnormal MRI scan, as you have seen. Dr. Mariam is mentioning a very good differential here. So the PRES, that must make sense. An excellent possibilities from Dr. Ziad. There's a PRES, CO poisoning, carbon monoxide poisoning, and vascular and CVT, say CSVT or CVST, cerebral venous sinus thrombosis. Yeah, they look all okay. They look very good. That's very good differentials. And of course, the very first HIE, the hypoxic ischemic encephalopathy. So this is a context of a patient with impaired consciousness and predominantly cortical and basal ganglia change. Reversible cerebral vasoconstrictive syndrome is again makes sense because of posterior predominance of the MRI pattern. So there is no so far there is no very diagnostic finding either in the clinical settings or in radiological settings, but maybe if we integrate both, and that's the heart of this particular teaching is to integrate both in no single mind, the neurology mind, the neurological the neurology doctor who can interpret both or at least combine the two differentials, the clinical differential diagnosis and the radiological differential diagnosis together. So again, Dr. Diana is mentioning HIE, viral post-viral encephalitis, because it is a cortex predominantly or a toxic metabolic pattern. That's an excellent differential. That's very, very good. So let's start with we have two differentials. One of them is a clinical differential diagnosis, and the other is a radiological differential diagnosis. And we can shortlist both of these two lists of differentials if we just checked for the overlaps. So if we combine both differentials and match the possibilities that can match either ways, we can reach down a very short list of differentials, and we can make a diagnosis based on that. And that's the essence of an integrative clinical neuroimaging. So let's swap back. I will go back to the description of what's going on, and then we will go on together. But before we start with the scans, so here's a patient who was found unconscious, hypotensive, with an evidence of shock because he has an acidosis and an increased lactate. So this is a person with a circulatory collapse, and possibilities here is predominantly cardiovascular. So that's the first thing. The second possibility is that he has something maybe iatrogenic. If he simply took a little more of his antihypertensive tablets, he would go shocked and hypotensive. A second possibility would be a seizure, and unwitnessed seizure, because he had few episodes of losing consciousness. We do know that stroke risk or seizures are higher in people who suffer from the metabolic syndrome, ischemic heart disease, and particularly if he had an element of cerebrovascular disease. So from a clinical point of view, he can be hypoglycemic, but this has been ruled out by the emergency blood glucose. And this can be a CNS infection. But however, we couldn't find a meningism or an evidence of focal neurology so far. So that's a clinical differential. So the clinical differential implies it's a circulatory problem. Second is a toxic or metabolic insult. So it's a toxicity from, for example, an overdosing of a medication, or homicidal, or something that is maybe sinister, or a drug abuse. In this context, there is no mention of that, but you should be vigilant to it. And the third possibility, living alone with no clinical data or circumstantial evidence, you may want to, like, if this patient developed a pneumonia and he developed a sort of low blood pressure which raised his culminating into a shock stage, and might be the rest of the sequelae based on that. So this is from a clinical standpoint. Let's go and focus on the radiological differential, and in the very third last step, we will mix and match what is clinical and what's radiological, and if both conditions can be met. So the initial CT likely ruled out big issues, like, for example, there's no gross pathologies, there's no subarachnoid hemorrhage, and enough for at this particular stage. There's no evidence of maybe an early stroke or a parenchymal hemorrhage as well. now to the flare, the initial flare. What is evident is that there is sort of effacement to the cortex. The signal is somehow doubtful, which is the case in any flare actually, because flare is an artifact prone sequence, and usually the flare has some artifacts around the cortical ribbon, around the periventricular area, so it is a little bit doubtful. But in the context when you have a change in the signal and a change in the appearance or the volume of the cortex, you are more confident that there is something predominantly cortical. I am doubtful of, before we go ahead, I'm doubtful of something here, but this is likely cerebellar and it's not particularly on the cortical ribbon. But let's go through, for example, this inferior occipital temporal sulci. They look bright compared to even local surrounding gyri, and they look a little bit edematous. Again, the whole surface of the outside of the temporal lobe looks suspicious to my eyes. They look effaced. So let's go, if you moved a little bit higher here. So this is again the area where I initially suspected still looks hyper intense. There are patchy hyperintensity here. I'm still not definite, but there's definitely something going on here. And if you compare the density of the sulcine gyri on the occipital region here, even compared to this part of the temporal lobe, there is here I can breathe a space in the sulci gyri, but not here. So it says hyper intense, and they are particularly losing any potential CSF space. So this is an effacement to the occipital region, spreading down to the occipital-temporal region. Also, this looks very fishy as well. This looks like an effaced sulcine gyri on the occipital-temporal region. Importantly, at this stage, we need to have a look to the hippocampus. Let me take off these hallmarks, but let's have a look in the hippocampus. It is relatively spared compared to the neocortical surroundings. So this very little hypointense line is the end of the lateral ventricle of temporal horn. So this is the amygdala, and the rest is a hippocampus. Sideways, we can maybe debate if there is a signal abnormality or not, but in any case, it is not comparable to the evident occipital-temporal region. So we got something fishy with the cortex so far. Still continues, still effacement here, still a little bit of cortical swelling here, and frankly abnormal basal ganglia. Predominantly, this is a head of caudate, both sides, and this is a lentiform nucleus, or putamen in particular, and the rest of the putamen, the globus pallidus, looks as well involved. So putamen is bilateral, symmetrical, nearly symmetrical involvement, the caudate, putamen, basal ganglia, relative sparing to the thalamus, and relative sparing to the amygdala and the hippocampus. However, we are facing a predominant gray matter disease and a gray matter pathology, if we can say. Again, the abnormal patchy hyperintensity is a sign that this is not particularly an artifact. This looks like an artifact. This is just like a good practical exercise. This looks like an artifact because it is just on the tips, on the top, and on the in the very convex part and the outside part of the cortex. And this is common in flare. But however, if you can see a pathology going down through the bottom of the sulcus, it is likely something abnormal. So usually, despite the flare is artifactual, like for example these hyperintensities, they are artifactual, but these ones are not. Simply put, so because usually the artifactual changes are happening on the surface. but not on the bottom, as I told you, not on the bottom of the Saltine guy, right? So if you found that pattern, this is likely an abnormal thing. And also with straining your eyes, this is not a normal volume. This is not the cortex is swollen as well. And again, this is medial occipital, and the part of the medial occipital is involved. Insula is spared, partially spared. However, you can see the widespread cortical changes. So again, I prefer to look to the scans from a neurological point of view, from the perspective of describing where is a lesion first, and then formulate what is next, or what is a lesion, what the lesion implies in terms of pathology. So again, if we just for the sake of time, this is a body of caudate, by the way, and still abnormal. Cortical ribbon bilaterally is involved across the top from the frontoparietal region. So white matter is spared, full stop. So there is no white matter changes so far in this scan. There is a predominantly gray matter pathology involving involving the basal ganglia, namely the caudate, putamen, globus pallidus, with some relative sparing to the thalami, amygdalae, cerebellum with some sort of sparing, the cerebellum and deep gray nuclei of the brainstem. The cortical ribbon supratentorially is also nearly symmetrically involved and involve the whole lobes, frontal, temporal, parietal, and occipital, with predominance over the occipitotemporal region, and it is more evident on the diffusion weighted. So these are the inferior temporal region, and the occipital region is significantly involved with the pathology compared to even to the flare. And interestingly, also the diffusion restriction shows a particular pattern. So it is a parieto occipital, and it is on the watershed area between, this is an ACA territory, and this is an MCA territory. So usually this pattern appears on the very top of the frontoparietal area, and if you slide down to some extent to the deeper part, you might find this pattern still valid. So this is an ACA area, relatively spared. The outside of the middle cerebral area is spared, but the most of the pathology happens in the watershed area. This is the occipital lobe and supplied by the PCA, and with some predominance or some selectivity to the watershed areas. Okay. So we, in the context, I think alone, clinically on its own, and radiologically on its own, it's difficult to make a pinpointed, straightforward diagnosis. This pattern of gray matter involvement has a list of peculiar differential from a radiological point of view. Namely, this is a toxic metabolic insult to the brain. So this includes circulatory problems, hypoxic ischemic encephalopathy, but this also equally includes hypoglycemia, prolonged hypoglycemia, also includes carbon monoxide poisoning, also includes PRES, also include viral encephalitis to some extent. So the list of radiological possibilities is still wide. However, from a clinical, with the clinical information in the back of the mind, we have ruled out the hypoglycemia, so it's not the case. We can search to some extent the CAO poisoning from collateral history and from some lab testing. So we might want to exercise that, and we got some evidence that there is a circulatory collapse. We have no evidence that there is a seizure, and I forgot to mention that radiologically this simply resembles post-ictal MRI changes. However, this is 5 days. It can continue for several days, but however, that might be one of the possibilities that you face here. So I think the overlapping appearance now is pointing towards something circulatory. And actually, the patient was in shock on the presentation. So, and this is actually a case of hypoxic ischemic insult to the brain. So these findings are typical findings of a person with hypoxic ischemic encephalopathy. So we have the this entity is most commonly happen with the stagnant or what's called the different causes can contribute to that, but the most common one is a circulatory collapse out of an arrhythmia or out of different hypotensive states, and that's actually the most common form. But if, for example, like in a case of hypoxia, the kind of airway obstruction, like a decreased inspired oxygen content, hanging, near drowning states, and also anemic when patients with severe anemia under some stress or on a carbon monoxide poisoning as well. And this is just a summary to what we have been discussing in the last few minutes. There is a spatial pattern, a pattern on the space of the brain. It's bilaterally symmetrical. It's posterior predominant. It's cortical more than the white matter, in the early stage particularly. And the caudate and putamen are more than the rest of the deep basal ganglia structure. The more severe, the more you will involve the white matter, the more you will involve the globus pallidus, thalamus, and brainstem and cerebellum. And also there is a temporal pattern. By temporal pattern, it means that these changes the changes you are seeing on the MRI are dependent on the time you are performing the scan. So it is, once you have a suspicion of an hypoxic ischemic insult, it's the first question you would like to answer is what is the time of this scan in relation to the onset of the presentation? And this is really crucial because the changes are really dynamic, and you need a good understanding of the temporal evolution of these changes to make a firm diagnosis of what is going on anyway. So in early, there is only diffusion changes, and followed by, later on, followed by flare changes with a pseudo-normalization to the diffusion changes. Diffusion changes starts 24 hours, some plus, with some technical problems that we will speak about in the next few minutes. And late, there's something called cortical laminar necrosis, and I would like to hint about it here today. Some basal ganglia calcification that's late and appears more in the CT, iron deposition, and appears as marked hypointensity in the basal ganglia and the white matter. Leukoencephalopathy, which happens as the later chronic stage in a proportion of these patients, and of course some atrophic changes. We have already seen that on the scans we had anyway. So let's, I'm sorry, let me just, yeah. Okay, so here is a patient with a late or late subacute changes with predominance of the flare findings. So there is an effacement here. Sorry. Okay, so there is an effacement in the central sulcus, frontal cornice, frontal gyri, parietal occipital region, various parts actually, and the basal ganglia, closely resembling our patient. And again, marked effacement here. So there's a muffling on the appearance in the differentiation even between the gray and white matter here. But there is also, in contrast to our patients, there is some involvement to the hippocampus, and it is somehow asymmetrical. It depends on the functional reserve. For example, if the patient had a compromise of his posterior cerebral here in this example, or the circulation perfusion is different between both hemispheres, or the circulation is restored for one reason or another to one hemisphere compared to the other, you would find a discrepancy in the images. And the leptomeninges, if you can see, this is still congested leptomeninges. You can, in a completely different clinical context, you might be absolutely valid to say that there is a leptomeningeal enhancement and there is a suspicion of a sinus infection. But in our case, that's not. There is a problem with my clicking. Okay, so that's it's going forward with these other scans. So if you notice for this particular patient, you can still find the basal ganglia abnormality. However, this started to normalize back with the diffusion. This is a pseudo normalization of the diffusion. The same as what happens with the stroke as well. So it happens in the acute setting. You find some diffusion restriction changes before the flare, and then both of them together, and later the diffusion would pseudo normalize, and the flare would continue for the rest. Interestingly, on this particular patient, so part of the cortical hyperintensity on the flare, particularly this area, it was hyper intense on the T1 pre-contrast. And this is a developing cortical laminar necrosis. And this is a continuity of this part of the cortex developing a cortical laminar necrosis. So there are a few layers within the cortex who are highly susceptible to hypoxic injury or toxic and metabolic injury more than to others. Namely, they are 3, 5, and 6. And these parts of the cortex, when the cells die with different pathomechanisms, they are surrounded and engulfed by phagocytes, and the phagocytes engulf the myelin, and this results in fat-laden macrophages, or and the fat appears as hyper-intense on the T1. T1 hyper-intensity is a very limited differential. So one of them is a fat. So here is a cortical laminar necrosis with fat deposition. And again, because and the other possibility would be a hemorrhage. However, this is this in our patient, this is another case of hypoxic ischemic insult, but with a hyper intensity on the corpus callosum here in the forceps minor. But on the gradient echo, it is high, blooming, and it appears as an iron related or iron containing pathology, which is likely a hematoma and some sort of hemorrhage, which is something not unusual in patients with hypoxic ischemic encephalopathy at some point. And we over time with chronicity, the myelin starts to change next. The cortex the cortical cells are highly vulnerable to hypoxic insult, and they are easy to undergo apoptosis and necrosis. Oligodendrocytes in particular, they are a little bit more resistant, but they are as well involved with global anoxia and global hypoxia to the brain. And the myelin sheath, the turnover of the myelin sheath is a little bit low. So once a patient is even recovering from his acute changes in the hypoxic ischemic changes, over time, if you undergo some follow-up MRI, you would find hyperintensity starts to creep on the white matter. And also you would find this is the same level. So you would find some volume changes with dilatation of the sulci and gyri and the dilatation of the lateral ventricle. So it's actually a dynamic changes that happens over several months even, but particularly with the volume changes and a leukoencephalopathy. And again, this is a particular patient. It's the same patient with across the timeline. This is the acute changes with some hyperintensity and swelling to the putamen, and caudate sparing the globus pallidus, as per the textbook, they say, and some involvement with the thalamus, but not particularly severe compared to the caudate and the putamen. Later on, changes start to recover, to resolve with some volumetric changes and a beginning of white matter leukoencephalopathy and atrophy of the basal ganglia at the end. And again, this is the hypointensity is a sign of iron deposition. Again, the hypointensity, the marked hypointensity on the white matter is iron deposition secondary to necrotic and atrophic changes that happen over time. just this is a little bit of an extra tip, but don't confuse yourself if you're not aware of for the moment of the weighting of the diffusion weighted scans. For the DWI, the usual one we perform is the B1000 is the usual one we use in stroke, which is in the top left images here. They are not as sensitive as when you increase a B value beyond the 1000, because when you increase the B1000, you sacrifice the tissue, the normal anatomy, and you render the diffusion is more sensitive to pathological changes. So that's the same patient, but however, with an increasing the B value, was able to pick the basic ganglionic and the cortical changes compared to the conventional stroke one we usually use. This is something a little bit more, let's say, it's not particularly advanced, but because it is something to do, but you would need to work in tandem with the neuroradiology team in the place where you practice. So it's just this can be particularly acquired in this particular context. If you are suspicious of an hypoxic ischemic insult or other toxic metabolic insult, you would like to include a different B values of DWI. So importantly, to speak about the radiological mimics. So I've spoken about the hypoglycemic states, post-ictal MRI changes, mitochondrial encephalopathy, posterior reversible encephalopathy syndrome, viral encephalitis. These we have no way to radiologically differentiate between these possibilities, including in comparison to hypoxic ischemic insult. And the only way is to have a clinical judgment from the clinical data you have. Only then you will be able to make a distinction between these syndromes. From the CT, I will speak about a couple of differentials as when we have the scans in hand. But let's go through just a typical cases from the literature. This is a hypoglycemic state, cortical predominance, occipitotemporal, some sparing to the deep white matter, to the deep basal ganglia, and of course sparing to the white matter areas. Some involvement to the hippocampus, particularly the left one here. That's a case of viral encephalitis. Unfortunate enough for the neurologist is to be mimicking the posterior predominance of the posterior temporal predominance, and of course with the diffusion restriction changes. Viral encephalitis tends to, most of the neurotropics comes to locate themselves within the gray matter, even either the cortical ribbon or the deep gray matter. So it's essentially the same, and comes with the same picture. So the only way to differentiate is the clinical and the paraclinical finding, rather than a radiological hallmark. That's mitochondrial encephalopathy with lactic acidosis and stroke-like episodes. Again, because it is a metabolic and an energy problem. It tends to have a selective vulnerability to the cortical ribbon and to some of the basal ganglia cells. Post-ictal changes, we have spoken about that, I think, maybe a few weeks ago, about a case with post-ictal MRI changes that can be really confusing if you're not aware that MRI does change after a prolonged seizure episode or a status epilepticus. And unlucky enough for us as well is just that you may even have basal ganglia changes and not just the cortical changes. Also unlucky for the neurologist, you have the posterior predominance in all these conditions, because this is a matter of this selective vulnerability depends on the perfusion of the blood of the brain and on the physiology of these cells. So whatever the insult is, it is likely to start to occur first in the posterior temporal region, spread through the watershed areas. As we've spoken, this is an anterior cerebral, this is a middle cerebral, and it tends to occur on the watershed zones between the major vessels. Dr. Diana is commenting about the sympathetic supplies. This is one other possibility as well, but however, it's not the only the only reason behind, because sometimes for the case of hypoglycemias, you don't have a perfusion problem, but you have a physiological disruption to the cells, and it tends to happen in the same pattern as well. And this is a post-ictal MRI changes. And here is a case with a severe hypoxic insult, prolonged hypoxic ischemic insult. If it reminds you with something, it reminds you with subarachnoid hemorrhage. And particularly if this is a very first scan, you would be in the chicken and egg situation. Is it a subarachnoid hemorrhage cause a collapse of the patient, or is it the other way around? This is not actually a subarachnoid hemorrhage. This is something called pseudo-subarachnoid hemorrhage, and it tends to happen with massive brain edema that occurs in the context of hypoxic ischemic insult. And this can be really can be very confusing. It's very difficult to detect the differences at some point. But however, there are some clues that you can rely on. For example, this particular patient, you have a subarachnoid hemorrhage in the basal cistern, but you have also some increased density of the falx, which is something related to the congestion of the intracranial compartment and not particularly a bleed, because this is not a bleed. This is just a pseudo-subarachnoid hemorrhage. So just be cautious when you have a global cerebral edema in a context of hypoperfusion or hypoxic or anoxic insult. Just make a second thought before making a diagnosis of a subarachnoid hemorrhage. It tends to occur in a very similar pattern, but however, if you slightly, for example, let's assume that this is a massive subarachnoid hemorrhage that will result in a whole cerebral edema. You would expect at this stage that it should involve the sylvians massively, which is not the case. You can see a subarachnoid space here, and it is clear. So, and there is still some subarachnoid space here, which is at this level of subarachnoid, you would expect that there are massive amount of blood in these regions, but this is not the patient case. So I'm just bringing this particular image just to remind you that if you didn't find a clinical context of subarachnoid and you had a patient with a massive cerebral edema, don't make a diagnosis of subarachnoid just on the CT head appearance. You would need some collateral evidence and maybe very supportive imaging evidence, but not particularly in this case. And that's another example as well. So let's assume if this is subarachnoid hemorrhage, this would include the whole basal cistern, but this is a vessel actually, and it's not a bleed because the rest of the sylvian fissure is spared, and the top, again, the continuity of the sylvian fissure is spared, and again the falx is enhancing as well, is hyper intense. Radiologically, you can have another trick when you can measure the Hounsfield units, but leave that to our neuroradiologist colleagues, not particularly for us. But the Hounsfield units sometimes can differentiate. And of course, you can have maybe an MRI, maybe a CTA to help or to support your diagnosis, or maybe other workup in appropriate clinical context. And just in a couple of minutes, I will remind you with what we need to do for these patients, particularly patients with after cardiac arrest and circulatory collapse. Definitely, you will need to keep a circulatory support to maintain cerebral perfusion. Ideally, this is a minimum of 35 millimeter mercury in mean arterial pressure. These particular patients are prone to electrolyte impairments, such as SIADA, secondary to the intracranial hypertension. They are under metabolic stress, cerebral-wise or brain-wise. They are under metabolic stress, and they may need some supplements, such as thiamine in vulnerable, in particularly malnourished or vulnerable population. Glucose is beyond question that you need to check and follow up. There is a promising therapeutic management, which is a therapeutic hypothermia between 32 and 34 degrees. this is, I think, this is the management lines that's shown some really proven benefit, other than any other thing, not the hyperbaric oxygen, not the NIMDA, so the other pharmacological interventions. They are doubtful, or at least they are controversial, and they are not established as a clinical practice. What you really need to do is a therapeutic hypothermia, if you have access and a facility to initiate that. If not, I think it is doable. As our cardiothoracic colleagues, they can induce that, and ITU colleagues can do that. However, in the best practice is to avoid a fever, aggressively treat any fever, because if your patient aspirated and he's developing some temperature, you need to aggressively control that, and you need to aggressively control the seizure as well, because they are prone to myoclonic seizures, and they tend to be intractable with some patients, and you need to effectively control them because they are an additional metabolic stress to the brain cells. And importantly as well is you need to set some early prognosis. As a neurologist, we are often asked to provide some prognosis on these cases. So we know the diagnosis, we know he had a cardiac arrest, but we need you as a neurologist to provide some prognostication on that. And I've snipped some clinical parameters that we can, just to remind you about them, that usually people with prolonged anoxia beyond 10 minutes, adults speaking, this way, and CPR duration more than 30 minutes, absent in day 3, if you had an absent light reflex, an absent motor response without sedation, this is particularly a bad prognostic. Of course, absence of brainstem reflexes is no rocket science. This is a sure sign of bad prognosis. And you do have some ancillary prognostication tools. The most useful has been the images and the somatosensory evoked potential. You need an absence of N20 component in the somatosensory evoked potential. And some of these changes we have spoken about already. So we have, if you had a pseudo subarachnoid hemorrhage, if you lost the gray-white differentiation or the gray-white ratio in Hounsfield unit, if they are less than 1.18, that's a sign of bad prognosis. And the cerebellar reversal sign, the extensive diffusion abnormality, and some MRIs can be helpful in setting like a long-term prognosis to patients. EEG is not particularly, in this context, is not particularly useful to make a prognosis. It's helpful to detect the epilepsies and maybe the diagnostic if it is not a hypoxic ischemic insult. However, particularly for setting a prognosis, it's not very useful. There are some fluid biomarkers, but they are not they haven't reached the clinical practice level so far. And to that point, I will stop, and I'm happy to take questions and discussions if you would like to have. So I would like to like you guys to help me as well with you leaving me your feedback. I will post the link right now here in the comments. This is just a 1 minute, 1 minute feedback. Just maybe, yeah. Thank you, everyone, of course, for your attendance. So there are some comments that worth discussion as well. So Dr. Ali mentioned a very good differential, the Creutzfeldt-Jakob disease. Yes, but not particularly in the context of an acutely unconscious state. But that's a very good one. Yeah, because it involves the thalamus and the cortical ribbon. That's a very important differential. So Dr. Diana is asking about paracetam. To what I have read is not. that's not. There are some trials on antagonizing the NMDA receptors for the excitotoxicity induced by the glutamate, but not particularly the any pharmacotropic agent has been found successful, to be honest.